Hello, I'm Dr. Rafael Escamilla, professor in the Doctor of Physical Therapy program and director of the Biomechanics Lab here at California State University, Sacramento. This is Justin in the Doctor of Physical Therapy program, one of my students. He's going to serve as a model. Today we're going to be talking about the structure, function, and pathology of the long thoracic nerve. The origin is the brachioplexus. Specifically, it comes from the ventral rami of C5, 6, and 7. These merge together to form the long thoracic nerve. Now, if we have Justin turn just a little bit, the long thoracic nerve is going to run down. If we have him lift his arm up just a little bit, it's going to run down and enter the lateral thorax in this area here and actually become fairly superficial. What is it, the lateral thorax? On the upper 8 or 9 ribs here is the origin of the serratus anterior. The muscle is going to originate here, and then I'm going to go and put the scapula here for a reference. It's going to wrap around this direction to the back, and then it's going to come all the way and insert into the anterior part of the medial border. So here's the anterior part right here of the medial border of the scapula. So in this position, it's in good position. If we get our pin out and use our pin as a force vector, when it pulls, it's going to be pulling the scapula this way, basically around the thorax. So this is called abduction of the scapula or protraction. Protraction or abduction, either one of those are synonymous. And the lower fibers actually are in really good position because they're coming up this way to upwardly rotate the scapula. So that's the inferior angle is moving away from the spine. That's upward rotation. So that's basically what it does. It's a C5, C6, C7 nerve, primarily gets its innervation from C6 and C7. Now, Justin, go ahead and come down and relax for a second and turn all the way in the back just for a second. And go ahead and watch the scapula. You can actually see the scapula elevate and upwardly rotate as Justin lifts his arm up. There you go. And go ahead and bring it down. And go ahead and bring both up at the same time, and they can take a look on both sides. You can see the inferior angle moving out. The scapula moves up and out and upwardly rotates. So that's what it should look like. So when you're assessing a client, you want to make sure there's symmetry on both sides. Other than just visually have them elevate their arms, you can have them press up against the wall. So we'll have Justin do that next. And if you're exerting force against the wall, you push against the wall pushes back, it tends to want to move the scapula posteriorly or away from the thorax. And we call this winging of the scapula. Primarily, the medial border is going to wing. So right in here. And winging is the medial border rotates laterally. So it rotates away from the spine like this. So Justin does not have a long thoracic nerve problem, but if he did, when he's pushing like this, you see the scapula wing out on the side of the injury. And of course, we see some symmetry, again, where it's really important to look for symmetry of the scapula nice and snug against the thorax on both sides. Another thing you can do is go ahead and come out from the wall now, Justin, and just elevate, flex your left shoulder up, flex it straight up, and again, you're looking for symmetry here, and go ahead and bring it down. Now do the same thing here. Rotates up. Now, if we have him come down a little bit, right about in this position, so about 150 degrees of flexion of the shoulder, and then have him hold that position as I pull down. The deltoids might be able to keep the arm up, but if there's weakness in the serratus anterior, you'll be able to feel the inferior angle of the scapula actually move in because the serratus muscle is trying to keep it in this stable position. So another test we can do is just let your arm rest in my hand, and then as I let his arm down, I'm going to be, again, feeling the inferior angle and seeing if it moves into adduction or downwardly rotates as I start. So try to keep your arm up there and know it's staying exactly where it should be, so we know that the serratus anterior is doing its job. Okay, so that is an overview on the structure, function, and pathology of the serratus nerve. I might mention one more thing as far as injury mechanism goes. How can it be injured? Well, it's a fairly superficial muscle right on the lateral thorax here. So trauma, like in sports injuries, getting hit hard on the side here, could injure the nerve. Backpack injuries, where you have straps that are going right up in this area here, prolonged time, and they're heavy, a lot of compression, that can injure the nerve, and even surgical when you go to do certain types of surgeries, surgeons are very careful to make sure they don't cut nerves, but sometimes it happens. So that's another way that the long thoracic nerve can be injured. Thank you very much.